everybody, I'm Zale Mednick, and welcome to another episode of Preconceived. In this episode that you're going to see, I spoke with Dr. Anna Lembke, who's a Stanford psychiatrist who I've had on the podcast multiple times. She's the author of the very successful book, Dopamine Nation, and she's an addiction specialist. In this episode, the question I really had was about alcoholism and about alcoholics. Is it possible if somebody is diagnosed with alcoholism or if somebody has an alcohol dependency, is it possible to drink in moderation as the treatment? Or is the mainstay of treatment, as proposed by Alcoholics Anonymous, of abstinence, is that still the gold standard? Because obviously most people want to say if they have a problem with alcohol, yeah, maybe I can get to a point where I can drink in moderation. But how effective is that? Do most people who try to treat their alcoholism with that approach end up rebounding? So that's what the crux of my conversation was with Dr. Anna Lembke. I hope you enjoy this episode of the podcast. And if you're enjoying these podcasts, please subscribe to us on YouTube, or you can find us on Apple Podcast or Spotify Podcast if you prefer listening to your podcast on audio. Have a great day. All right, Dr. Anna Lembke, welcome to the podcast. Thank you so much for joining me.
Well, you're very welcome. I'm happy to be back.
You are back. This is your third appearance.
Yay.
I feel honored. I was just telling you beforehand, you've been your book, Dopamine Nation, is one of my favorite books, and it really, really took off, became an instant bestseller. And that's what we talked about last time. And I recently listened to an episode with you on the Daily Podcast, one of my favorite podcasts. Yeah. And I thought I should reach back out to you to talk about something that's not necessarily in your book about Dopamine Nation, but is obviously very much on theme with a lot of the work you've done in your career about addiction, which is alcoholism.
Yeah, I'm excited to talk about alcohol. It's true. It's easy to just not talk about it, in the midst of all the other things we can get addicted to, but super, super important. And one of the most common addictions, really.
Certainly our phones are more addictive, probably, in terms of the number of people that are affected. But it's easy to forget that alcohol obviously wreaks havoc on so many people's lives, and for so many years was kind of, when you thought of addiction, you thought about alcohol.
That's true. And, you're right. It is hard to get numbers on like digital media addiction or tech addiction. It's also not yet officially in the Diagnostic and Statistical Manual. So some people would argue it's not even possible to be addicted to digital media or technology, whereas, alcohol has sort of been there from the very beginning. The interesting thing about people with alcohol addiction today, though, is that you hardly ever see just pure alcoholics anymore. Almost everybody is a polydrug user. So that's also a big change from previous generations. I would say that it's more that like almost everyone dabbles in a lot of different things because drugs are so readily available. So, people who tend to drink too much often smoke too much or use, designer pills or have problems with, sex or gambling or, whatever it is. They used to call it the white glove alcoholic, which is really just a way of saying people who are just like pristine alcoholics and there's nothing else. That is exceedingly rare today.
I'm guessing who haven't been given a diagnosis of it or are dependent or have an unhealthy relationship with alcohol. And in some cases, I think labels are helpful. In some cases, I think labels are detrimental because they kind of put a bracket on what is considered something that's problematic enough that it warrants treatment. But I guess for the purpose of this conversation, it might be useful to have a diagnosis, to have a definition of how you kind of define alcoholism, or if you think that really it's not even that productive because it really does take so many people out of the conversation who probably maybe don't classify as alcoholics, but really, for all intents and purposes, alcohol is not doing good things for their lives.
Well, tons of great questions in there. So much to discuss. Maybe a good place to start is just sort of by unpacking the language a little bit, because the language of addiction is really changing a lot in the past 20 to 30 years or so. So, for example, if we look at the Diagnostic and Statistical Manual of Mental Disorders, which is what we base our diagnosis of addiction on, that manual doesn't even use the word addiction. the DSM-5, which is the fifth edition, uses the term use disorder. So if your problem is alcohol, you have an alcohol use disorder. If it's nicotine, it's a nicotine use disorder, et cetera, et cetera. So there's a lot of conflicting, confusing language, but generally for our purposes, I use the word addiction synonymously with alcohol use disorder and alcoholism. They all mean that you're dealing with somebody who has an addiction to alcohol. In terms of how we diagnose it or define it, alcohol use disorder, alcohol addiction is considered a brain disease. There are innate biological risk factors. There are brain changes that happen with exposure. But nonetheless, we're not yet at the state of the art where we have a brain scan or a blood test or anything remotely like that to diagnose it. We still base it on essentially behavior and subjective reporting of one's relationship to alcohol. And there are 11 criteria. We usually summarize them as the 4 C's: control, craving, compulsions, and consequences, especially continued use despite consequences. Control is self-evident. Compulsion is where a lot of my mental real estate is preoccupied with getting my drug, using my drug, and then doing it all over again, as well as a level of automaticity with the drug use. But craving can take many different forms. It's not just the thought like, I need a drink really badly right now. It can just be this elaborate narrative that our brain comes up with in a nanosecond to rationalize why drinking is okay, or drinking is not problematic, or why I really need to drink because of X, Y, and Z. So craving takes many forms. The mental health consequences, physical health consequences, relationships, jobs, psychospiritual consequences, legal consequences that people can experience as a result of their alcohol use. Importantly, the diagnosis of alcohol addiction is not based on quantity of alcohol consumed. This is not because quantity is not relevant. Okay, quantity is relevant. The more you drink and the more often you drink, the more likely you are to meet criteria for an alcohol addiction. But when they were coming up with the diagnostic criteria, they wanted an overarching criteria that they could apply to every substance. And so they didn't want to have quantity or frequency in there. Also, in general, it is because it is a behavioral illness. We usually don't base it on quantity and frequency because you could have somebody who's drinking, relatively speaking, a lot of alcohol and still not meeting the 4 C's criteria. And so they technically wouldn't meet criteria for an alcohol use disorder. Likewise, you could have someone who's not drinking very much, actually, maybe only binges once or twice a month, but every time they do, they have serious consequences. So I hope that explains.
That's a really good summary to 10 questions I asked all in once.
Sorry.
No. I'm sorry for asking 10 questions. Anna, I'll tell you what kind of spawned this episode in my mind. I know a couple people who would call themselves alcoholics, and one of them is very big into AA. Big into AA makes it sound like it's a fad. They go to meetings every week and have for 5 or 6 years, for over 6 years now. And it's really transformed their life. And at the pillar of AA, from my understanding, and obviously I'm not an expert in this, it comes down to not necessarily the idea of abstinence, but all those ideas converge on the conclusion that the way to treat alcoholism is you really just can't engage with it at all. And I know that has been a persistent model for many decades. However, I know other people who would say they have issues with alcohol, whether they identify as alcoholics or not, or have alcohol addiction or not, who would say there are some other models out there and you don't need to be fully abstinent. I think I can acknowledge I've got an alcohol issue, maybe be addicted to alcohol, but I can treat it in a way where I can still get to an end point that's different, that's not abstinence, an end point where I can enjoy the casual drink. And I found that interesting because some of the people in AA, or most people in AA, would say, no, that's just not the model. You can't do it. Or maybe some people can do it, but it's just so rare that you need to subscribe to the AA model. So let's start off, I guess, by exploring the AA model. What is at the core of AA, and why is it believed by AA that abstinence is the key?
Let's start with the requirements for membership to AA, because I think that's a nice place to really enter into the AA philosophy. The only requirement for membership in AA is the desire to stop drinking, which means that you can show up intoxicated at every single meeting as long as you have a goal of abstinence from alcohol. And undergirding that goal or that mandate is the idea that people who are alcoholics in AA terminology essentially have an allergy to alcohol. And the big book of Alcoholics Anonymous will use this idea of allergy, that even one drink is going to cause harm, if only that it leads to more drinking. But on the same time, so the goal is abstinence, right? There has to be a desire to stop drinking, even if you're still drinking. The ultimate goal is to stop drinking. And they very much use a medical model as well as a psychospiritual model. And the medical model equates alcohol, an alcoholic having an allergy to alcohol. But it would be incorrect to say that that the only goal of Alcoholics Anonymous is abstinence from alcohol. Because in fact, at the real core of Alcoholics Anonymous is the spiritual transformation, and the idea that that getting into recovery or being sober from our addictions is not just about not using; it's about a whole new way of being present for our lives and present for other people. It's very values driven. It did emerge originally from the Oxford group, which was a Christian evangelical movement that was founded on the idea of catharsis through confession and other, basically kind of religious values. So specifically speaking to that, if you are just abstinent from alcohol in AA, but you're not working the steps and working toward this spiritual transformation, you are what they would call a dry drunk in Alcoholics Anonymous. That is to say, you may be abstinent, but you're not necessarily in recovery. A dry drunk is somebody who's not drinking, but still engaging in the types of maladaptive interpersonal behaviors that we often see, in the disease of addiction. But you are absolutely correct that the overarching philosophy has always been and still is in Alcoholics Anonymous that once an alcoholic, always an alcoholic, and the goal needs to be abstinence. And that has really shifted in the world and in the field of addiction medicine outside of Alcoholics Anonymous in the last 30 to 50 years. Starting simply with something called spontaneous or natural recovery. That is the realization that there are people who drink in an addictive way for much of their lives or for long periods of time. And then one day say, you know what, this is not healthy for me and not good, and I'm just going to stop. And they're able to do it. They never go see a psychiatrist. They never go to an AA meeting. They just spontaneously or naturally recover from that. So that's interesting. And then you have an early scientific literature. This is mainly Sobel and Sobel's work, where they tracked folks who had met criteria for alcohol addiction, who were, many of them got into recovery through Alcoholics Anonymous, but then after a period of time decided that they wanted to go back to drinking, but they wanted to drink in moderation. And what they document is that some of those individuals are able to do that, contrary to what Alcoholics Anonymous states, which is, once you've been an alcoholic, you can never go back to drinking in moderation. Now, of course, what Alcoholics Anonymous might say, in rebuttal to that phenomenon is, well, those people weren't really alcoholics, right? Because a truly severe alcoholic would never be able to go back to drinking in moderation. So it's an interesting area of discussion. And, what's happened in the last 20 to 30 years in the field of addiction medicine in particular has to do with the whole idea of harm reduction, meaning that maybe a person would continue to use their substance, alcohol or whatever it is, but they would use less. They would moderate their use. They would use in ways that would mitigate the harmfulness of the use. And this has really taken hold in the field of addiction, this whole idea of quote unquote meet patients where they are, which also is just practically the goal that we have to adopt, because we can't force anybody to do anything, right? So if people come in and they say, I'm drinking in a way I don't like, I ultimately want to drink in more moderation. If that's their goal, even if we don't think they're likely to be successful, we have to help people toward their goal. Now, I will interject that in clinic, what we find is that even if the long-term goal is to drink in moderation, we recommend at least a month of abstinence from alcohol to reset reward pathways, because what we found is that people are much more likely to be successful in their goal of moderation if they first stop drinking for a while. That was probably more information than you wanted.
That was perfect. And I want to put a
Okay.
pin in some of the kind of more modern approaches over the last couple decades for a moment to better understand a couple elements that you spoke about with AA. This idea that it's an allergy, that kind of theory lends itself well to abstinence, so to speak, right? Because depending on your theory of what leads to alcohol addiction, it might dictate what kind of treatment you follow. So if it's an allergen, for example, you would never medically say it's okay to put an allergen in your body. So that's
Well,
what,
now let's hold on there, because just a bit of devil's advocate, right? We do have this approach to other types of allergies where you slowly expose people and see if they can develop some kind of tolerance.
you're right. I just realized that as I said it with peanuts, for example, and you see that in
Yes, right,
kids, right?
right.
So, but I
But they're
guess
different because what we have here is people who have been using in large amounts and then already experienced significant harms from use, who are now trying to go back to using less, which is different from the peanut allergy.
I guess how effective is AA before we talk about some of the newer models that are out there? Because ultimately, if AA is super effective, and I guess there's two prongs to that. One is how many people is it effective for, and then it is for the people who it's effective for, how effective is it? But how effective is AA? Because if it were a model where you said, a lot of people just can't do it, a lot of people, I guess it's a bad phrase, fall off the wagon, so to speak, or don't subscribe to it and they stay addicted or they go back and relapse, then you say, okay, we need to look for a new model. If you said to me, AA has actually been really, really good for a lot of people and it's been quite effective, then there's an argument to say there might be some other ways where you can kind of treat it in a different way where you don't have to be abstinent, but there's so much risk there that it might not be worth the reward. No pun intended, because we're talking about the reward cycle here. So I guess the question there is, how effective do you view AA? Are you a proponent of AA in general? Granted, everything is case specific, but in general, how do you perceive AA?
Well, let me frame this first by saying that for reasons that I don't fully understand, we are in an era of AA bashing. And, inevitably, any program that's been around for 100 of years, there will be criticisms, many of them legitimate. But I feel like in the last 10 to 15 years, there's just been this surge of kind of anti-AA sentiment, which, again, I don't fully understand, but it's out there. If we want to understand how effective is AA, we can go to the scientific literature. Although you can't do a controlled study, really, half of these people to AA, half not to AA, that simply wouldn't be ethical or practically feasible. There is now enough accumulated evidence in the scientific literature to show that AA is really quite effective for those who actively participate. And again, I want to underscore, for those who actively participate. For people who don't go to meetings, don't work the steps, don't get a sponsor, it's not going to work. Just like any intervention, it's not going to work if you don't do it. But for those who actively participate, including those who are mandated by the courts to go, we see really remarkably good response rates on par with the response rates that we see for other mental illnesses, like CBT for major depression, or really any of our mental health interventions, whether they're a pill or some form of individual or group psychotherapy. On average, you get about a 50% response rate, which again is on par with what we see for other interventions. Furthermore, if you compare active participation in Alcoholics Anonymous with seeing a medical specialist, an addiction medicine specialist, it looks like AA is as good as that in the short term. And if you follow those folks out to a year, it looks like AA is better than a medical professionalist. Now, what's playing into that? Probably the fact that AA is free. It's pretty much every church or community center basement, community center room in the world. You can find an AA meeting. And it integrates a sober social network friendship group with people's everyday lives, which is just absolutely key. Whether or not, it's specifically something about that spiritual transformation, we really don't know. I suspect that also plays an important role, but that's my perspective. I don't know if there's any real science to support the psychospiritual transformation piece of it. Furthermore, if you look at the most severely addicted, right, the folks who have tried everything else and haven't been able to get into recovery, AA works best in that population. So it's a very interesting thing where there is pretty good evidence that, active participation in AA works. And yet we sort of have, we see it every day in clinic, people who are, for a variety of reasons, really resistant to going to 12-step meetings, or will endorse having gone to a couple meetings and it was terrible, or having gone to more than that and having had a bad experience. And again, it's not for everybody. There's no doubt about it. It's not going to work for everybody. And just like very upfront, the philosophy and the spiritual piece is going to, for some people, just be a non-starter. Although even there, I would say there's more wiggle room than people realize, because the higher power in AA is however you define it. It can be the community itself. It doesn't have to be a supernatural or even, like entity larger than just community.
Yeah, from the people I've spoken with, because I said to them, how do you kind of, I don't want to say well, yeah, to an extent, get past the spirituality, because I know they're more secular. And they say, you know what, there's different ways to interpret it, and this is how I interpret it so I can get past it. But the resistance you spoke of, I am guessing, is probably partially related to the spirituality and the Christian nature of it. You said it has its roots in evangelicalism. And then probably I'm guessing that there's a lot of work, there's a lot of meetings, and it could intimidate people. What would be the argument against AA? Um, and when I say that, I don't mean to make it sound overly binary, because it ultimately doesn't matter. If somebody comes to you and they say, I don't want to do AA, then you're going to treat them in another way, because that's better than saying you should go to AA. But from the psychiatrist's perspective, from the patient's perspective, is there something you can understand about, yeah, the AA method? There is something there that kind of, it is reasonable that people are looking for another method.
Oh, absolutely. First of all, if your goal is moderation, especially if that's your immediate goal, AA is not the group for you. Remember, the only requirement for membership is the desire to stop drinking. And if you don't desire to stop drinking, you don't want to go to AA, because your goal is orthogonal to the goal of the organization. Having said that, again, we have folks who will go to AA for a time, stop drinking for a time, and then change their goals. Goals are not immutable. People can change them over time. And sometimes people, will change them. They may, after a period of abstinence in their lives getting better, decide, hey, I want to see if maybe I could drink again. So that's one thing. I wouldn't refer somebody to AA if their goal was moderation. What comes up quite often is social phobia, right? Feeling like they just can't do well in groups. But I never just take that at face value, because actually, when AA is working the way it's supposed to, it can be a very safe place to connect anonymously with other people struggling with the same problem. But that can be something that comes up. The higher power thing comes up all the time. Again, I gently push back on that, in the sense that the higher power is really whatever you define it. The key there is that you identify locus of control outside yourself, or you recognize that your ability to control this particular behavior is beyond you, and that you have to hand it over. Now, there are folks for whom that fundamental pivot is just off-putting or abhorrent. For them, they want to feel that they have control. They want to regain control. They believe that they can regain control. And the whole idea of, this surrender to a higher power is just really antithetical to a fundamental view they have of themselves in the world. So, in that case, I might recommend something, like smart recovery, or one of the other offshoots of AA that doesn't include the higher power piece. And then the other thing that people will talk about as well, I'm really worried that if I go to an AA meeting and I hear a bunch of people talking about, their escapades drinking, that's going to make me want to drink. And we sometimes call that drunkalogs, hearing people's drunkalogs. And what I say in response to that is, yes, that's a potential danger. We do hear that from folks. But if you're experiencing that at a meeting, that's probably not a meeting where good recovery is happening. If you're in a meeting where there's really good recovery and people are telling their stories, they're not romanticizing, their alcoholic escapades. They are drawing from a deep well of shame, regret, and remorse. And this is a safe place where they can talk about these things and kind of experience the de-shaming of not being alone, and very much look toward a hopeful future where they are not, not drinking. So those are just, some of the many different caveats. I also want to add that a lot of AA meetings have gone online, and we actually don't, as far as I know, have good evidence on whether or not that works. I myself am a bit of a skeptic about whether or not online meetings are as effective as in-person meetings. So I will often also really encourage people to go to in-person meetings. If they're well on their way in recovery and they just want to use an online meeting as a bit of a booster, that's one thing. But I'm not sure that people with severe alcoholism can get into recovery just by going to meetings online.
You mentioned moderation there, and that's, for me, I guess one of the cruxes of it. The goal of moderation. How realistic is that goal? If there were an approach out there that said to me, you know what, you can still drink alcohol in moderation and we can get you to that point, I feel like I would probably say, well, let me make that my goal. And I feel like most people who identify as alcoholics would probably search out an option that says you're not going to fully have to give this up because they're addicted to the substance that they're being told you have to give up. So how effective, when someone comes to you because AA wouldn't provide that sort of goal, how effective is it when somebody undergoes some of the other therapies we'll talk about, like smart recovery, cognitive behavioral therapy, or meets with you? How effective is it to create a goal of, I'm not going to stop fully, or like you said, I'm going to stop fully for a month, but afterwards we're going to get to this point of moderation? Because if that isn't effective, then that obviously supports the model of, whether it's AA or something else, it supports a model of abstinence. If there are a lot of people who truly have addictions to alcohol who try to get to a goal of moderation, but they're not able to achieve that, then the proof is kind of in the pudding.
Yeah, well, I think what you're getting at is the real potential danger of sort of holding moderation out as a possibility for someone for whom it never would work. And that then in and of itself can essentially delay their recovery. Now, many of the folks who come to us, their goal is moderation, right? And many of them have already tried moderation and failed. So now they're like, well, now I'm going to go see a doctor and see if I can, moderate, under the care of this doctor, because maybe they have something better or different. And we do have medications, that specifically have been shown not just to help people with abstinence, but also reduce the number of drinks on drinking days. So, and now the GLP-1s, like Lembke and Wegovy, are also being shown to help people achieve abstinence from alcohol, and also moderate their alcohol use. So this is, it's not completely cuckoo to think, well, I haven't been able to moderate on my own. Maybe a doctor can help me moderate. But on the other hand, I think you're making a really good point, which is in holding moderation out to somebody for whom moderation is never going to work, are we just delaying really the kind of care they need? And how I talk to patients about it is just like I don't have a crystal ball. Okay. I can tell you this is what we see. So first of all, we always recommend a period of abstinence of at least a month before trying to moderate. If you're not able to go even a month without using, you're not going to be able to moderate, right? And maybe you even need a higher level of care to just stop drinking because you haven't been able to do it. So that's one thing. But assuming that they can go for a month and not drink, then before we enter moderation, we need a very specific plan for what that's going to look like. What are you going to drink? How much are you going to drink? What days are you going to drink on? What are the circumstances? How are you going to keep track? How are you going to stay accountable? All of those things, the more specific, the better. Because we've seen that the people who are going to be successful are more likely to be successful with a very specific plan a system of accountability, and a tracking system. So that's already a lot of work right there, right? And then in terms of how people do, as I say to my patients, I say I have patients who try moderation and instantly are right back into the full-fledged addiction. And there's like not even a second when they were moderating. They're right back into drinking in their severely addicted way. And it becomes clear, oh, moderation is not an option for you. I would say the vast majority of people who try moderation slowly but steadily slip back into heavy alcoholic drinking. But maybe initially they can moderate for a couple weeks, a couple months, maybe even more than a couple months. But most people eventually end up back where they were. So then that's a learning experience, isn't it? Because now you've got it under the care of a doctor and empathically trying to help you set those goals, and still you weren't able to moderate. Probably moderation is not in the cards for you. And then we have this third category of folks who actually is able to moderate with an enormous amount of effort and what I call self-binding strategies. That is both literal and metacognitive barriers between themselves and their drug of choice that allows them to exercise enormous willpower to drink in moderation, and sometimes with the addition of biologics, right? Different medications that help them moderate. And what's interesting about that group is that a large percentage of those individuals will say, well, I can do it, but it's so much work that it's not worth it to me. I'd rather just abstain. Like abstinence is actually easier than moderating. So that leaves you, in my clinical experience, with a tiny little sliver of people for whom, once they've met criteria for an alcohol use disorder, especially, a severe alcohol use disorder, a tiny little sliver of people that actually achieves moderation. And by the way, we have good data with alcohol for what moderation looks like, which is to say it's no more than 2 standard drinks per day for a man, no more than 1 standard drink per day for a woman, unless you're 65 or older, in which case it reverts to the woman measures no more than 1 standard drink per day, ideally with, a couple of days of abstinence in there. The healthiest people on the planet drink no more than 1 to 2 standard drinks per week. Okay, and those people are even healthier than people who don't drink at all. Is that because alcohol is good for us? Probably not. It's probably because people who drink only 1 to 2 standard drinks per week also do a lot of other things in moderation, like exercise and eat. And also in your non-drinking group, you have what we call sick quitters. These are people who used to drink in an alcoholic way and now are on the liver transplant list, for example. But the bottom line is once you're drinking more than 1 to 2 standard drinks per week, you are increasing your risk. And again, for men, once it's more than 14 standard drinks per week or more than 7 standard drinks per week for women, you're in a very high risk category in terms of all-cause morbidity and mortality. So when we're shooting for moderation, we're shooting for those numbers, right? Those evidence-based numbers. There's some dispute about those numbers. There are some people who, some studies have come out and said, actually, it shouldn't be 14 per week for men. It should be just like with women, no more than 7 standard drinks per week. No more than 4 on any given day. But the bottom line is we do have good data that we can aim for. And most people with significant alcohol disease, moderation is a struggle if they're able to do it at all.
And it's sad because there's a bit of a trial and error there for a lot of people, as you said, because you said there a tiny sliver of the population of patients who are addicted can get to a point of moderation. And I would assume that, and it's people listening to this who are addicted to alcohol would probably self-interestedly, understandably try and say, well, I'm probably part of that, or I could be part of that. I have the willpower. I could be part of that, even though there is a brain disease component to this where just because you say I want to be a part of that doesn't mean you will be a part of that. So if we look at it as, okay, moderation, not unachievable, but not necessarily the most realistic of goals. Abstinence is probably the most realistic of goals. Not real. Abstinence is probably the best way to a recovery. AA isn't the only model there. There's other models. There's smart recovery, cognitive behavioral therapy, there's medications. Talk to me a little bit about some of those approaches and what you do when you're seeing somebody when they have shifted their goal to the point of, I don't want to be drinking alcohol anymore.
Right. So in terms of, the efficacy of self-help or mutual help groups like Alcoholics Anonymous, as I talked about, we have good evidence that Alcoholics Anonymous works when people actively participate in in-person meetings. We don't have good studies on online meetings, and we don't actually have a lot of good data on the offshoots or the different types of 12 step or of different types of mutual help groups, not even 12 steps. Some of them are 12 steps, some of them aren't. So those are things be like Dharma recovery, which is sort of a Buddhist centric approach, smart recovery, which is kind of like based on sort of CBT kind of orientation. We've got moderation management, which just like the name pronounces, is really for people who are the goal of which is to moderate. And interestingly, they recommend a month of abstinence prior to moderating as well. So this is sort of a truism that I think a lot of different people have landed on. And so I would say, you have a lot of different types of mutual help groups. And then, especially since COVID, you've got the explosion of all kinds of online communities, which might not even call themselves, mutual help groups or peer recovery groups. They might not even have a philosophy or a literature. They're just people getting together, trying to help each other with alcohol related problems, So that's actually kind of a new and exciting area as more and more people, even people without alcohol addiction, are moving toward drinking less or moving toward abstinence. So this has been a very interesting shift just in the last 10 years or so. More and more people, including young people, are becoming very interested in not drinking alcohol. And I don't know exactly, what's contributing to that shift. It could be the increased awareness around potential harms, including, the risk of cancer and other health problems. It could be the rise of other drugs replacing alcohol, everything from psychedelics to digital media to, you name it, all the designer things that people are trying now, cannabis, cannabis gummies at a party instead of alcohol, stuff like that. But there has been an interesting move kind of away from alcohol, even among people who are not diagnosed with alcohol problems.
When you're chatting with a patient, is there sort of a cognitive, we've done episodes on cognitive behavioral therapy before, and I know that's a big conversation, but is smart recovery revolve around cognitive behavioral therapy to an extent? And what's your approach with them? And I imagine it's a huge timeline sometimes to get them to the point of saying, I want to become abstinent. But when they do decide they want to become abstinent, are you trying to then walk through their relationship with alcohol, trying to get them to comprehend it better? And is the idea that a better comprehension of alcohol and their relationship to it will then lead to their ability to be abstinent? I know what I just explained isn't quite cognitive behavioral therapy. That's more of a psychoanalysis of it. But what's your conversations look like if they are coming to you and they're depending on you and your meetings to keep them on track?
I wouldn't say that we push our patients toward one thing or another. What we try to do is try to chunk the behaviors in discrete periods of time that seem manageable, and through small, iterative, positive changes, get people to reflect themselves on what they want to do next. So, for example, our very standard first early intervention, especially for people who are not at risk for a life-threatening withdrawal from alcohol, because as you know, alcohol withdrawal can be life-threatening. So we want to make sure that we screen people, make sure they're not vulnerable to that. The biggest predictor of future withdrawal is past withdrawal. So we kind of rule those folks out because they need more medical support. But in general, we ask people for 30 days of abstinence from alcohol, or for that matter, whatever their drug of choice is. We warn them that they will feel worse before they feel better, but that if they can just get through those first 14 days, the sun may come out. They may notice they're feeling just much more positive, better able to sleep, less irritable, less anxious. And so that little experience, because it is a kind of experiential learning, can provide the internal motivation for what to do next without our really having to railroad it one way or another. People can be like, wow, I feel so much better. I think I want to do another month of abstinence and kind of see where this goes. Or they'll say, you know what? I do want to go back to drinking. And then we'll say, okay, let's make a plan. Let's be very specific. And then they'll make a plan and they'll be able to do it or not be able to do it. Well, a month later, we'll meet again. How did it go? Well, I wasn't able to do it, or I was, but it was really hard, or wow, that was great. I never thought I'd be able to drink. And you take it in small iterative chunks. Like, I think thinking about like, I'm never going to drink again in my whole entire life, that is really hard. And even in AA, they talk about it just taking one day at a time. I think that's really smart. Like you can have these longer term goals, but let's focus on just the here and now and the shorter term goals. And I think people just tend to be much more successful in that. Now we are sort of hopefully empathic persuaders, right? So if somebody's coming up with a plan, this is now their fourth time to try to drink in moderation, and they've had all these serious consequences. I'm not going to just be like, oh, okay, that sounds great. What's your plan? I am going to say, well, now let's think back. Remember the last time, and then there was this, and remember that happened. Do you really think that's going to be a possibility for you? And then they will most likely come, well, actually, no, I don't know. Why am I even thinking this? It's obviously not going to work. So it's more of a dialogue. And this is, of course, this has been now captured under the catchphrase motivational interviewing. But of course, we've been doing this in the field of psychiatry and addiction treatment for well before, this moniker motivational interviewing. But it's basically the idea that you get people to try to become self-aware of, what they're doing, the outcomes, the pros and cons, and then use that increased awareness to make better decisions for themselves going forward.
That makes sense, and that must be challenging for you and psychiatrists because what you're telling me, what I'm hearing is you're not just going to tell them, even if they've said, I want to be abstinent, and then they say, well, maybe I've changed my mind. You can't force them to say, well, no, you said you were going to be abstinent, so we need to come up with a specific plan. I'm holding you to what you said before. There's a limit to which you can do that for multiple reasons. One, it's not practical. Two, ethical questions there, even if you think it is the right ethical decision, it's ultimately their decision and you can remind them. But that's really helpful. That's a very helpful way to understand it, that the same way AA says one day at a time, you're kind of looking at this as one meeting, one segment, one chunk of time at a time, really.
Yeah, and I think there's also an enormous amount of respect for autonomy, in the field of addiction medicine, while also realizing that addiction is the loss of agency. So there's a little bit of paradox there. But even in the throes of, very terrible addiction, people do preserve their ability to choose to accept or not accept help. They may not be able to choose to stop drinking. Their disease may be so far along that they can't stop on their own. We do see that a lot, but they can choose to reach out for and accept help. And we try to be here and provide that help when people are ready to accept it. The other thing I would also say, which is why, a period of abstinence is so vital in the beginning, people can have all kinds of ideas about what their goals are, which really change when they get into recovery and actually experience not drinking and have so much more clarity on like how much better their lives are, when they're not drinking. And then they have very different goals.
You wrote Dopamine Nation, which we talked about at the beginning, and I can't give enough of my humble praise for that book because it's just so fantastic. It's really well written, great examples. The reason I bring that up is obviously alcohol is an addiction, but you talk about a lot of different types of addictions in that book. And I guess the last kind of theme I want to get to here is when you look at alcohol addiction and you look at other addictions, it's probably easy for a lot of people to conflate all addictions together and say, well, if this is the way that you're supposed to treat alcohol addiction, granted, you've just said it's a customized approach for a lot of people, then this is how then it would be applicable and could be extrapolated to how you treat other addictions. Are there specific things where you would say, yes, the model for how we approach alcohol addiction is a good model for a lot of other addictions? Or would you say there are certain things that are specific to alcohol? Just thinking about the way addiction has expanded to social media, for example, to cell phones, it's impossible to have an abstinent mode. Not impossible. It's close to impossible to live in this world without a phone, with most careers, without email, right? So things that we are now newly addicted to, newer technologies that didn't exist 30, 40 years ago. So that's a long way of saying what tenets of alcohol addiction recovery are easily applicable to other realms of addiction and what might not translate so well.
Well, we do know from the neuroscience that all rewarding substances and behaviors work on the same common pathway. They all release dopamine. The more dopamine that's released, the more likely that substance or behavior is to be addictive. And that as a general rule, we can conceptualize all addictions as the same disease process. So intervening the way we do for alcohol for other addictions has actually proven to be quite effective. You see that, from the ways that we can use medications, the same medications we use for alcohol addiction, not universally, but some of them. We've applied those for other addictions. For example, naltrexone is an opioid receptor blocker. It's been shown to help people drink less or abstain from drinking. We've also seen some efficacy with sex addiction and naltrexone, gambling addiction and naltrexone, obviously opioid addiction and naltrexone. So there is more commonality than you might think. And then also, if you look at Alcoholics Anonymous and the 12-step groups, there are so many offshoots of Alcoholics Anonymous for almost any addictive behavior you can imagine, including tech addiction. There is a 12-step group for it. So in a lot of ways, we apply the same exact principles. But your point is well taken that people can abstain from alcohol. They can't abstain from food. They can't, in large part, abstain from all technology because their jobs and their lives are dependent on accessing technology. So what we do there is we circumscribe a subcategory within the larger category that constitutes the addictive element. So food in and of itself, grown, under the grace of Mother Nature, at its most basic form, is generally, not particularly addictive. Like broccoli, you don't eat like a head of broccoli and then want to have
you don't hear
20
too
more.
broccoli ads.
Right. But if you take broccoli and you add some sugar and you deep fry it and you put some hot chili pepper sauce on that, all of a sudden you've got something that's potentially super reinforcing, and we will all be vulnerable to eat too many. So people with food addiction, have them sort of categorized. Okay, what is the subtype of food that once you start eating, you really can't stop? For many people, it's sugar. And it turns out cutting out sugar is really hard because so much of our food supply has sugar, salt, flavor, and fat. But basically, you try to abstain from those foods. Same thing with technology. Like when we use these devices as tools, they're amazing. When we use them as drugs, not so good. So if you go to Internet and Technology Addicts Anonymous, an online, ironically, 12-step group for helping people with tech addiction, what they usually talk about is, I never use my device for entertainment or to change the way I feel. And that's kind of a nice bottom line, right? Like, yeah, because that's when I get into trouble, right? When I'm watching YouTube videos for entertainment or to escape whatever I'm feeling right now, then I could be watching for 2, 3, 10 hours. Who the hell knows what? I could never stop. So I think these are the types of things that we think about when we think about something other than alcohol. Now, interestingly, what can come up with alcohol is, well, how about non-alcoholic beverages? Is that okay? Good question. We don't really have a lot of data on that. Some people find that it becomes a trigger for them to want to drink real alcohol. Other people say, no, it's a great substitute because it has such negligible amounts of alcohol that it's not going to change the way I feel. So, it's an interesting time because moderation, we have to talk about moderation. Why? Because some things you just can't abstain from, and because many, many people are interested in moderating and not stopping. And so we have to have the conversations. Yeah, I would just say, the alcohol use disorder, alcohol addiction is a devastating disease that affects many, many people all over the world. And we continue to need to focus on that and help those folks struggling with the most severe form of alcohol addiction, especially in a society where it's normalized and promoted as a social lubricant. Very, very hard to get away from it, and very, very deadly for the people who are most severely addicted, and other people as well, right? When people People who like smoke pot, they sort of don't get up off the couch. But people who use alcohol in risky ways, they drive their cars. And so it's a really important area to focus on. And we have to have a lot of empathy for people with alcohol addiction because it's really hard to get a handle on in some cases.
Well, Dr. Anna Lembke, thank you so, so much for joining me again. A lot of, a lot of really, really a very fascinating explanation of the different approaches to treating alcoholism, especially in terms of kind of how you establish a goal with a patient and how a
Yeah.
lot of the work really is done there. And then it's kind of day by day in terms of achieving that goal. If you haven't heard me say it already, you should read Dopamine Nation. Just look up Anna Lembke online and you can find Dopamine Nation um, on Amazon or wherever you get your books. And you can also look at her other book that she published a while ago about the opioid crisis, which is a deep dive into the opioid crisis, which we've all heard a lot about, obviously, over the last several years. Anna, thank you so much for joining me on Preconceived.
You're very welcome.
And thank you, everybody, for listening to another episode of Preconceived.